Hi, my name is Dr. Karen Semmens. I am part of the Dakota Geriatrics Workforce Enhancement Program. Along with Dr. Chris Hendricks, we have developed a series of micro-lectures on the age-friendly concept of the 4 M's: mind, medication, mobility, and what matters most. This presentation is focused on the M, mind. This presentation is on the other dementias: vascular dementia, frontotemporal dementia, Lewy body dementia, Parkinson's disease dementia. Our objectives for this presentation are to recognize the differences between the 3 other types of dementia besides Alzheimer's, identify the symptoms of each of the 3 other types of dementia, and the treatment for the 3 other types of dementia. We'll start with vascular dementia, previously known as multi-infarct dementia. You might have heard it called that in the past. This is considered the second most common cause of dementia, with Alzheimer's disease being the first. What causes vascular dementia is any condition that disrupts the blood flow in the brain. That can be from uncontrolled diabetes for a lengthy period of time, where there's too much sugar in the vessels and it causes constriction of those blood vessels. And there's not enough blood getting through those blood vessels if they're being clogged. There can be bleeding from the brain from a stroke that can cause some brain damage. Other types of lifestyle behaviors that can be a risk factor for vascular dementia are smoking and obesity. Vascular dementia is one of the dementias that could be prevented or reduced. The symptoms and the condition can be reduced by changing some of those lifestyle symptoms or lifestyle habits that we have. Some of the symptoms of vascular dementia: memory loss, misplacing items, impaired judgment, decreased ability to plan, loss of motivation, and hallucinations or delusions. The onset of vascular dementia is usually 65 and older. So if you think of the lifestyle habits that we have of smoking, obesity, uncontrolled hypertension that can cause a stroke, or uncontrolled diabetes, it's going to take a long period of time for those diseases, those risk factors, to affect the vascular portion of the blood system. The progression is a progressive disease, so it will get worse over time. Vascular dementia sometimes is seen as a stepwise decline, so it's like you go down a step and you have some more memory loss, and then you might plateau for a little while, and then you go down again, depending on what event is occurring in the brain. You might have some little small strokes that will be causing some decrease in memory loss. The treatment and therapies: once a person has any type of dementia, it cannot be cured. You can treat the symptoms and you want to manage the behavior. But again, this is a type of dementia that can actually be prevented by lifestyle changes and controlling blood pressure and diabetes. Another type of dementia is called the frontotemporal dementia. This sometimes was known as early onset dementia. The cause for this is that there are tau proteins and other proteins that accumulate inside the neurons in the frontal and temporal lobes. That sounds kind of confusing. The frontal lobe is in the front of your head. The temporal lobes are in the sides by your ears. These also have some plaques that will occur that will prevent information from passing along, similar to Alzheimer's disease. Alzheimer's also has the plaques that will form that will prevent information from passing from one neuron to another. If you can't get information passed from one neuron to another, that neuron dies, and all of the other neurons around it will die, so there's brain death. This is considered the rarest form of dementia, and this usually has some kind of genetic component in it. From onset to the end of life is shorter than other forms of dementia, and that's probably because it starts earlier on in life. Some of the symptoms that we'll see with frontotemporal symptoms: in your frontal lobe is kind of where you have your filters so you don't say the wrong things in public, that you dress appropriately, that kind of your behavior is kind of in that kind of appropriate behavior is kind of in that frontal lobe portion of your brain, the forehead. So usually what we'll see in somebody who has frontotemporal dementia is that they start having some kind of odd behavior that's out of the ordinary or more impulsive. All of a sudden, somebody who's been a saver, you saved up money all of their life and saved things all their life, go out and buy a brand new house when they don't need it, a brand new car when they don't need it. So that's kind of the symptom that we'll see the first, is that there's that kind of out of the ordinary behavior. They'll also have some difficulty planning and organizing. Their emotions might be kind of flat. Their face might not show too many emotions, or they might have excessive emotions, laughing, crying, behavior again that's kind of out of the ordinary. Might be some movement problems where their hands shake, and there might be some balance and walking problems with this disease. Difficulty with language, with the production and comprehension. There's the two parts of speech, where your production is where you think about what you want to say. Comprehension is what you hear people say. Can be problems with both of those with this frontotemporal, because the sides of your head up by the ears, that's where language occurs. Okay, like we talked about, the onset of this is usually between the ages of 45 and 64. The progression is quicker, more rapid, so from the time of diagnosis to the end of life is faster with this type of dementia. The treatment is going to depend on the disease, and we'll talk about treatment as we go through the rest of the slides, because the treatment is kind of similar for all the different types of dementia. The next type of dementia is called Lewy body dementia, and this again has some abnormal deposits of protein. Those proteins are called Lewy bodies, and they also develop in the nerve cells of the brain or the neuron. So pretty much with Lewy body and frontotemporal, there is the little plaques that are going to form inside the brain, going to cause some brain death. Those deposits, they form clumps, which affect the brain's ability to send messages, like it happens in Alzheimer's disease, like it happens in the frontotemporal. This disease also is going to affect thinking, memory, and movement. So you'll probably notice that it's very similar with the different types of dementias and Alzheimer's. You kind of have the same symptoms. It's just kind of to determine the difference of them is going to be the progression of it. What's the underlying cause of it? With Lewy body dementia, there's going to be some cognitive decline, just like there is in the other ones. Some difficulty concentrating or staying alert. This one is a little bit different because there's a movement disorder, so similar to Parkinson's disease, and we're going to talk about that one in just a minute. But as the disease progresses, you have the loss of coordination, that flat facial expression somebody might have with Parkinson's, that muscle rigidity where they can't move their muscles anymore. Having trouble with sleep. Can have excessive daytime sleepiness, so sleep a lot during the day. They might sleep for a couple days and then they'll be awake for a couple days. There are some visual hallucinations that go along with Lewy body dementia. With this dementia, confusion starts first, and then there's the movement disorder. So when we talk about this being similar to Parkinson's, with Lewy body dementia, you have the confusion before you have movement disorders. The onset of this is usually 50 or older. Again, this is a progressive disease, and the treatment is going to depend on the symptoms. So if they're having trouble sleeping, you want to think about what you want to give to help the person sleep. And we'll talk about more treatment in just a few minutes. The other part of this Lewy body is the Parkinson's disease dementia, and you don't really hear too much about this. This is similar to the Lewy body dementia, only the person has a diagnosis of Parkinson's first. So you have the movement disorder that comes with Parkinson's before you have the confusion. So I'll just say that again. So Lewy body dementia, you have confusion, then you have the movement disorder. Parkinson's disease dementia, you have the movement disorders and a diagnosis of Parkinson's, and then the confusion comes after that. So like we talked about, the behaviors can be similar, the treatments can be similar, but our goals, we want to be the same for all different types of dementia. We want to maintain the independence of that person as long as possible. We want them to stay home in their current residence as long as possible. The residence and where they're staying is familiar to them. When you move somebody who has any type of dementia from where they're very comfortable and aware of their surroundings to an area where they're not aware of their surroundings, you're going to see a change in their confusion. We want to maintain their ideal weight range, so keeping them from becoming malnourished, from becoming dehydrated. Maintaining a toilet routine, so we might want to be toileting them every couple hours so that they don't become incontinent, that they can maintain a good bowel schedule. And of course, you want to keep them free from injury, making sure that the environment is safe. You're simplifying the environment, removing the throw rugs and any clutter and cords and things like that that could get in the way of the person being safe. And then establishing a good sleep routine. So how do we manage care? Let's talk about communication first. We want to talk to the person, get their attention before talking. Be careful about touching them if they don't want to be touched. Face the person when they're speaking so they can see your lips moving, so they can see that you're talking to them. Try to use simple sentences with one idea or one instruction. Speak in a calm manner, using an adult tone. Don't baby talk or elder speak, oh, honey this or honey that. So being respectful and using their name. Avoid words or phrases that might be misinterpreted or sarcasm. One time I had told somebody who had dementia let's hop into bed, and the person started hopping. I was like, okay, that was the wrong thing to say. So offer opportunities for simple decisions. Do you want apple juice? Do you want orange juice? So do you want to wear this pink outfit or this green outfit? Do not get into arguments with them. It's very discouraging for the person when you say, well, gee, Mom, you should remember this, or Dad, you remember that. I just told you this. Don't argue with them. They're doing the best they can. Try to provide distractions if they get stuck on something and they keep saying the same thing over and over again, or something is starting to bother them. Try to provide some distractions for them. Provide efforts with positive feedback. Gee, good job brushing your teeth, or oh, you did a great job stirring up the pudding, or whatever. Observe any nonverbal expressions and behaviors, and sometimes we have to anticipate their need. They might not be able to express what they want. We might want to, if they drink coffee and they've always put sugar in their coffee, now all of a sudden they're putting salt in their coffee because sugar and salt are on the table and they're getting confused. Take the salt away. So anticipate some of those needs that they might have. Maintain eye contact with the person when you are talking to them so they know that you're focused on them and that you're trying to pay attention. Some of the treatment is going to vary on the stage of the disease. And non-pharmacological treatments, reality orientation will work fine in the beginning stages of any of these dementias. If they are still able to orientate, if you tell them what the day and time it is and where they are, fine, great, use that. If it gets to the point where when you're trying to do reality orientation and it starts to frustrate them, switch from reality orientation and use validation therapy. Go back in time with them. If they were a school teacher and they're back in school teaching English, talk about that. Use reminiscent therapy along with that validation therapy. Boy, you were an English teacher for a long time. What was it like? How did it change? What was your favorite class to teach, or something like that. Try to keep the environment simple for both safety purposes and to eliminate clutter so it doesn't overwhelm them. Use the communication tools that we talked about earlier on the last slide, making sure that if they have glasses or hearing aids that they have them in and that their glasses are clean. If they have dentures, make sure that they're fitting right so it doesn't cause any pain in their mouth when they're eating. So some of our behaviors, how do we manage these behaviors? The behaviors are probably the most difficult and the most frustrating for any type of caregiver. So there's going to be physical or disruptive behaviors, maybe some hitting, kicking, biting. What we want to do is to identify and avoid those situations that trigger disruptive behaviors. If it's something that always occurs at the same time of day, identify that and prevent that from happening. Recognize warning signs. Any cursing that might occur, any pacing that might occur. We used to have a gentleman who when he had to go to the bathroom, he would touch his belt. And if he didn't get him to the bathroom right away, he would urinate wherever it was wherever he was. So we would recognize that was a warning sign that he needed to go to the bathroom. Always address them in a calm, quiet manner. Be soothing. Try to avoid arguing, like we said, or reasoning with them, or reacting. Sometimes that's just going to cause more behaviors. Try to distract, like we said. Reinforce any positive behaviors, and allow maximum decision making and participation in any of the events. We did have 2 ladies one time just talking about participation, and they both went down to the activity room, and they both like to work with yarn. One would take the yarn off of the ball of yarn, and in the next room we had another lady who would like to take the loose yarn and ball it up. So we kept the 2 of them separated. One took the yarn off of the ball, the other one put the yarn back in a ball. So they were participating and they were having a good time. Some other behaviors that we might see are verbally abusive. And again, we don't want to take these behaviors personally. This is not about us. It's about where they are in their disease. And sometimes they're going to resist care, which is not uncommon, because now we're helping them with their ADLs. We're helping them bathe. We're helping them groom. And they've always been told, don't let strange people touch me. Well, now all of a sudden there's strange people that are trying to take care of them. So they're going to possibly resist. And they could be cold. It's cold to give a bath. So, making sure the environment is conducive to allow them to get their cares done. Sometimes they're going to undress inappropriately or dress inappropriately, not knowing which layer to put on. I've taken care of women who put their dress on first and then their slip on top of that and then their bra on top of the slip. So, again, we don't want to humiliate them or tell them they did it wrong. We just have to gently try to get them to dress the proper way. Some kind of repetitive actions, wandering during the day, and then night wandering can be very dangerous, especially if they think that they're going to go out and drive their car and they get in the garage and it's not heated. It can cause some problems with freezing or hypothermia. There can be some inappropriate sexual behavior. And then the suspiciousness that can come along with some of these dementias, that they just don't trust the person and they don't know the person. They don't recognize the person. They've lost something and now it's that caregiver's fault because they have stolen it. So there is some of that. Some of the treatment pharmacologically, again, is going to depend on the stage of the disease. And if you saw the other presentation on Alzheimer's, these are the same medications and the same medications for memory impairment, behavior management, and depression. Treating it the same, it's just going to depend on the stage of the disease and which medication works best for them. Avoiding any medications in the anti-anxiety category that would cause any delirium. We want to treat the person with respect. Even if they start to decline developmentally, they're still an 85-year-old. If we have to help them with their shoes, we help them with their shoes. We don't want to have any negative communication by saying, well, you should know how to do this. You're 85 years old. We're going to help them with that. Always maintaining respect. Making sure that we're meeting that what matters most. What matters most to this person today is getting their tie on because it's Sunday. Okay, then that's what we need to do. Treating them individually, allowing them as much independence as possible, and freedom. Like we talked about, do you want orange juice or do you want apple juice? You want to wear this pink blouse or this green blouse? Maintaining dignity at all time. Trying to have some connection with the person. And then support the family and caregivers, because this is a very difficult disease. Oftentimes, if you go to a support group, you will hear them say that this disease, as it progresses, is harder on the family and caregivers than it is on the person, because the person doesn't remember. So, our case study for this is a 77-year-old female resident, Helen. She's on the skilled nursing unit and she has a diagnosis of Parkinson's disease. You've been taking care of Helen for the past 2 years as her primary CNA. You have been off work for a 2-week vacation. When you walked into Helen's room, you noticed that she did not recognize you, and she always has in the past. She used to call you by name. And she's having hallucinations. She is seeing small children playing on the floor. So what would we report to the charge nurse? We would want to talk about how, 2 weeks ago when I left, Helen remembered who I was. right now she's seeing children on the floor, reporting that there has been a change in her mental status. How would you respond to her statements regarding the hallucinations? Finding out what it is that she's seeing, where she's seeing these children. They're playing on the floor. Oh, who's all playing on the floor? What are they playing with? Trying to get to that, because if you argue with them and tell them there are no children on the floor, you're possibly going to cause extreme behavior. So trying to figure out exactly what is it that they're seeing on the floor. Would you correct Helen's reports of children playing on the floor? Depending on the stage of the disease. If she's adamant that there's people on the floor, and there's people on the floor, again, what are they playing with? How many children are they? Are they boys? Are they girls? Do they look like your children? If it becomes to the point where the children are bothering her and are causing her some distress, we might have to say, Helen, those children have gone. They're not here right now. I don't see them here anymore. Maybe they've left. So trying to get that off of her mind and distract her. If this becomes an issue where the hallucinations becomes a problem, you might have to go, you might see that the provider will order something for hallucinations that will prevent that. So when we're looking at the different types of dementias, which type of dementia do you think she might have? She would have Lewy body dementia, because she's had the confusion first. Doesn't say anything yet about her movement disorders, but she is having hallucinations. So that would be the type of dementia that she has. And that is the end of this presentation. Here are the references that we used. Thank you for listening, and we'll talk to you later.